Okay, welcome to season 2 of Strength and Chiro. This is episode 9. Can I get an episode check, Dr. Stephen? Is it episode 9?
It is episode 9.
Thank you for that. Right before I introduce our fantastic guest, can we just get a check? Can we have a view of the dog? Let us know where the dog is.
So let's check.
Dog check. Beautiful. We are very, very privileged, very blessed to have an incredible master. I would definitely use the word master. It seems like a very genuine, amazing person, just chatting to him for the last half an hour. Very intelligent, a master of his craft. So we're very, very happy to have him on the podcast. So welcome to our podcast, Joel Proskewitz.
Thank you very much.
How was that pronunciation?
Absolutely perfect.
Cool.
Couldn't have said it better myself.
I'll just quickly go through and let our listeners know a little bit about you. So Joel Proskewitz has been working to improve the lives of athletes, low back patients, and general population clients for over 25 years. After becoming a national champion in two of the most demanding sports, karate and bodybuilding, and with an excess of 30,000 hours of one-on-one training, Joel has dedicated his life to the improvement of exercise techniques and systems to allow his clients to achieve the very best outcome and enhancing their pain-free performance. An internationally acclaimed strength coach and low back rehabilitation specialist, Joel travels the world teaching and sharing his philosophy to a variety of clinicians and trainers and has worked with thousands of fitness professionals on enhancing their skill set. For the past 19 years, Joel has worked closely with Professor Stuart McGill in the rehabilitation of low back pain, or lower back pathologies rather. He also teaches both the McGill clinical and performance courses and is one of only 2 people in the world who teaches for Professor McGill. Joel has been a presenter at high-profile health and fitness conferences such as the Discovery Fitness Convention and the South African High Performance Institute, giving advice on topics including strength training for women, Olympic lifting for sports performance, and practical nutrition for fat loss. He has also featured in leading publications such as Men's Fitness and Men's Health. Joel currently works with many high-profile clients, including Olympic medalists, international musicians, and world record athletes. He is the CEO of Performance RX in London, UK. Once more, welcome to the podcast, Joel.
Thank you very much, Brogan. Thanks, Stephen. It's quite interesting. I very rarely update anything on my website. It's just not something that I do. And, because right now my world has got nothing to do with personal training anymore. I don't train general clients. I don't lecture on fat loss or anything like that. My world is 100% spines. That's all I do. I see necks, thoracic spines, and lumbar spines. The thoracic spine is still a mystery to me, and I think to most people, and we're trying to get our head around it. But literally, my world is 100% dealing with spinal pathologies, pre-post surgery patients, failed surgery patients, and funny enough, I'm getting a lot of patients now coming to see me that have only got a little bit of back pain, but want to get empowered to understand how to look after their spine as they progress into their later years, which is actually very, very interesting to deal with and quite satisfying, because it's nice to know people are taking their health and well-being into their own hands and empowering themselves, which is outstanding.
Well, I'll tell you what, the intro I knew was too good to be true. I clicked over to the website and I was like, it's just all here. This is perfect. I thought to myself, I hope it's not too old. At times, I've had to go with previous guests. I've had to go through and pick out and write, these intros. And I remember the first time I had Locke on the podcast, I did a lot of work to figure out, as much of what he's done. And so I rattled it off. And then he's like, what about the rest of it? He goes, we'll just forget about the rest of it. I said, oh, I'm sorry, what did I miss? But anyway, so it's funny about that. But hey, just before we move on, I will formally introduce Stephen to his own podcast. So funny enough, I call him Redmon, but it's pronounced Redman. And so I would like to, welcome you to your own podcast, co-host Dr. Stephen Redman, who is also the Tony Stark of chiropractic. Welcome to your own podcast, Dr. Stephen Redman.
Thank you, Brogan. It's wonderful to be here.
I think I would like to start with a brief introduction around your story. Obviously, I introed some of the things you've been doing. Very impressive, amazing stuff. But one of the unique things about you is that you've been through it's fair to say, a hell of a lot of pain. And you've come out the other side. You've been able to use that, learn from it. I clicked over and I listened to your 3-part story on YouTube. So if anyone's interested, I'll put it in the show notes. If you want to go listen to the 3-part story, go ahead and do that. I have to say, I really felt for your situation, and it's very cool to see you go on now and have such a passion to help other people using your own knowledge, like that intrinsic kind of struggle and pain that you had. You've switched it around and you're helping people. So much respect for that. Yeah. Would you please give us just a brief rundown on a little bit about your story and what you've been through kind of brought you to this place?
So, as I said, I'm fully involved in the world of spines and everything and anything to do with spines these days. But back in 2020, so just when the world went into COVID lockdown, it was around about March or April of that year, I had been dealing with a spinal pathology for the last 30 years of my life by that stage. And just in simple terms, I had something called a spondylolisthesis, which is a fracture in the spine where the spine actually slips out of place. And, most people that have got them don't even know that they've got them. And I lived with mine, and it was through that I met Professor Stu McGill, and I got involved in the world of spines because I was trying to sort out my own problem. Yep. Anyway, it got to March, April of 2020, and symptomatically, I became quite severe. In medicine, we grade things mild, moderate, and severe. So I went up the pain scale to more severe. And what was getting me was not the fact that the pain was becoming more severe, but I started to get what we call neurological deficits. So I started to lose function in my feet, especially just on one side, which was worse. And really the game-changing thing for me was because I was a frontline worker, I was allowed to come to my private gym during lockdown. So one day I brought my kids, just my two girls, just to get them out the house, and we did a little bit of a workout. And I finished doing about 2 sets of about 20 reps of body weight squats, and no load or nothing. I've done it my whole life. I got home that night, and the pain was the most severe that I've ever experienced. The ridiculous pain down my leg. I couldn't sleep. Anyway, I'd had enough. That was for me the moment where my brain just changed gear. And the next day I phoned my surgeon, and I've been working with this particular spine surgeon for about 6 or 7 years prior to my surgeries with him. So I phoned him and I said, listen, I'm done. I've had enough. My toolbox is literally down to nothing. I need to explore surgical interventions. So we decided, and I elected to go straight for surgery. I didn't want to go down the route of epidurals and injections because structurally my nerves were being compressed, right? They were literally being, you could actually see the bone compressing the nerve. So we did a call. It was myself, my surgeon, Stu McGill. We were just chatting about things, and I brought Stu in because, he's the man whose shoulders carry my feet, really. And so we had a long chat, and my surgeon and I discussed exactly what procedure I was going to have, what hardware we're going to use. Anyway, we decided on a 360 fusion. And what that is, they replaced the disc with an ALIF cage, which is this. So that is a fusion cage that goes in between the two bones. And then a week later, you go back in, and then they put screws in your back like this to support the structure, the fusion structure. Anyway, to cut a very complex and long story very short, I was supposed to have 2 surgeries. I landed up over a period of 12 months having 7. Wow. It was a very, very complex procedure. My surgeon was faced with a lot of decisions that are not easy decisions to make. And one thing I will tell you, because people always say to me, you had 7 surgeries with the same surgeon. Why did you do that? And I will tell you categorically now, standing here over 2 years past my last surgery, that if it wasn't for this man, I don't think I'd be standing here today speaking to the two of you. He literally, and there's no drama to this, he literally saved my life. The man's an absolute genius. I think he's one of the most experienced spine surgeons in the world. And he kept his head about him. And he said, amidst the storm, he was very clear, very concise, very non-emotional, and said, Joel, these are the steps that we're going to take. It's going to take us about a year to 2 years. He said, it's going to be hell. But he said, trust me, I'll get you there. And gentlemen, as I'm standing here, I can honestly put my hand up and say that I experienced every symptom and pain presentation that a spine patient could ever experience. I can tell you what nerve pain is. I can tell you what muscle pain is, bone pain, fascial pain, a neuropraxic pain. That's when your nerve is stretched, which is insanely painful. It's honestly, it's life-changingly painful. However, what that did is it allowed a silver lining to come through. And as someone who deals in spinal rehab, I'm a patient that's experienced literally everything that a patient can go through. And with that, it was an absolute gift. In simple terms, the tragedy was a gift at the end.
That is it's an amazing story. My mother-in-law planned to have that. I'll tell you, when I was reading the report and talking to her about it, it was a frightening thing. It's a scary thing. You need multiple medical professionals in the sense of.
Well, you have an access surgeon. So what surgeons do these days, right? Spine surgeons, is they use a vascular surgeon, especially if they're going to do an anterior approach, because with fusions, you've got 6 or 7 different variations of fusions, both pros and cons to every single one of them. Okay. And in some instances, if in certain individuals, the surgeon can't approach from an anterior aspect because if they've got certain issues in their past medical history, or if they've got cardiovascular issues, or they've had a previous abdominal surgery, that is off the table. So when we go in from the front, it's always a vascular surgeon first. Yeah. And then once the vascular surgeon has sort of moved all this stuff aside, then essentially, and your spine is fully accessed, that's when the orthopedic or the neurosurgeon will come in and then start doing the discectomy and the fusion, et cetera, et cetera. So it's a massive, massive operation. It's not something it's not a no disrespect to knee surgeons, but it's not a knee arthroscopy. And now with people utilizing the term, and I'm talking surgeons using the term, we can do it minimally invasive. The minute you say minimally invasive, a patient thinks, wonderful, right? Yeah. That means there's going to be less damage. I can get moving a lot quicker. Minimally invasive is minimally invasive for the surgeon, not for the patient. Okay. It's just not. Yeah. And minimally invasive doesn't mean better. It just means different. Yeah. And there's so many things that are said in the medical community, and I'm a huge advocate for my medical colleagues, right? I need them, right? In certain instances, especially with the demographic that I deal with, right? But their words sometimes get misinterpreted, and the patient then, either is extremely anxious because they've been told, all this gore that's going to be happening to them, or they are under the illusion that, they're having this minimally invasive surgery and they're going to be back to doing their yoga practice within 5 weeks after having a fusion. And that's not true. I'm very involved in that world, and I can tell you that fusions are massive surgeries, and indicated correctly for the right person at the right time in their journey can make a massive effect on a positive effect in the long term or the longevity of their spine. And I'm standing here today telling you that probably the best decision I ever made in my spine journey of recent times was to actually go ahead and have the fusion. I train 6 days a week now. I've got more flexibility now post my fusion than I did prior to my fusion, because everyone says, oh, you can't have a fusion because you're not going to be able to move your spine. Well, I've got a different story there. You hear this all the time. Don't have a spinal fusion, have a disc replacement, because if you have a spinal fusion, you're not going to move your spine. Well, I'll tell you this. And again, it's very dependent on your symptoms and your pathology prior to having a fusion. But most people lose their mobility and flexibility and a whole host of things because the pathology doesn't allow you to move normally. Right? So there's a whole host of muscle compensatory patterns going on. There's a whole host of neurological guarding going on, right? Now, when you do have the fusion, all of a sudden, those pathology or that pathology has been eradicated.
Yep.
And all of a sudden, if you respect your new spine, if you understand, if someone's taught you what you can and what you can't do with your new spine, you will find when nature feels the time is right, that your movement, your range of motion, your flexibility all comes back significantly improved compared to what you were prior to the surgical procedure. So, I can tell you right now, I'm moving better. I can squat better. I can pick things up from the floor better. I don't abuse what I've been given because I've been given a second chance, but that's a whole different discussion. Wow. So again, one of the myths that I'd really like to just absolutely shatter is that a fusion reduces your motion. However, my caveat, in the United States specifically, Stephen, and you'll know this, right? A lot of surgeons do multi-level fusions, right? So they'll do long construct fusions. In the United Kingdom, it's a little bit different because they usually, if they do need to do, let's say, a 2 or a 3 level, they usually start off with a 1 and they say to the patient, let's do that, see how you go for the year, and then we'll consider doing the other levels, right? Now, again, in the US, it's a little bit different. And probably, I don't know New Zealand and Australia, but they'll do a 4 or a 5 level, or sometimes if they've got to do an adult deformity fusion, they'll fuse from like T12 to the pelvis, and that's what we term a long construct. You will feel a massive reduction in your movement ability. That's different, okay? But I personally don't deal with a lot of long construct fusions because they're just not done a lot here in the UK. And I can tell you, when you rehab the person properly, their movement's amazing.
Your perspective on this is very new to me. And being someone that is so passionate about catching people before needing surgery, to hear like the benefits of surgery from you is refreshing. I try not to be attached to any like ideology, but I try to be objective. And to hear that, it's actually quite shocking. Like Locke turned to me a few weeks ago and said, I'm busy for the rest of the year. I'm traveling. I'm sending everyone to you. All his virtual clients. He's sending everyone to me. I was like, okay. And so I'm just so fixated on like getting people better so they don't need surgery. And surgery in my mind has just become the boogeyman. And so to hear you talk like that's refreshing, in the sense of me being like, well, maybe I've been creating a bias, or I've been creating a little bit of a false reality around surgery being this bad, horrible thing that no one, that is the enemy, when, like you said, it can really help some people, and it's helped you. And this is where I'm getting to my question. I know you've had a long career. I've heard you talk about different parts of your career and what you've done. Right now, as it stands, are you primarily dealing with people post-surgery as opposed to people who are helping people move so they don't need surgery, or you doing both?
No. I deal with every spinal pathology, pre-surgery, post-surgery, no surgery. So no, not at all.
Cool.
What has happened since my surgeries, I'm getting a large percentage of people coming to see me to determine, do they require surgery, right? So they're coming to me like as a second or a third opinion. So a lot of people will go see a neurosurgeon, an orthopedic surgeon, and then they'll come and see me.
Yep.
And then they may have one viewpoint from the neuro, another viewpoint from the orthopedic, and then I'll sit down. Now, by no means, and I'll say this publicly, I do not have the power to say to someone, you need surgery, right? And none of us do, right? Because that's a decision between their surgeon and them, right? Between the patient and the surgeon, not between any of us, unless it's an emergency, unless we see red flags. But take that off the table. My perspective is to assess them to determine, can we potentially avoid the surgical intervention at this time because other people had left some stuff on the table and they didn't fully assess you to determine mechanically, actually, you can get pain-free.
A lot on the table.
Pain-free.
A lot, like a lot, right? Like this, like
a lot.
I mean, there's
a lot on the table.
It feels like the majority are just not trained in university. The curriculums are not adequate to what they need. Just feels like, there are people pushing back against McGill. There's a whole community that pushes against McGill now.
That doesn't bother me. You know why? Because they don't understand McGill. They've never been on our courses. And if they have come on our courses, they've come there with a particular thought process to come and shoot us down, not to listen to us.
You engage with them, you can tell within the first few sentences of what they're saying to you, they haven't read any of his books. They haven't read his studies. They haven't in any of that. They just have got a screen snapshot of a few buzzwords, and these buzzwords are always usually pig spines. It drives me nuts, but I digress. That's not what I'm talking about. What I'm just trying to say is I feel like, in terms of the curriculum of the programs that are being taught internationally to manual therapists and various types of clinician, we need to do better. We really, really need to do better. And I find, the work that you and McGill are doing is just fantastic, that education, even just those ideas of being able to, movement proficiency, helping someone move, spinal hygiene. I personally wish it was in more of the university's curriculum. That's what I'm trying to get to.
Absolutely. And, I think, I can't speak for what they're teaching at university, right? I'm not a physical therapist. I'm not an osteo or a chiro, but the interesting thing is I can only speak for when my patients come to see me and they tell me who they've seen beforehand and what they've been given. And the interesting thing is, regardless of the resolution, none of them have ever had a proper explanation as to what is going on, right? Because, and that's where I start. We've touched on, how do I assess or what I do, but the key for me is, can I assess to determine what they are going through and what is actually happening? And then can I take a highly complex world like the spine, right, and simplify it so that this person knows exactly what's going on? And I think probably that's one of my strengths, right, is the fact that I've delved so much into the spine that I can take a highly complex situation and I can really simplify it in bullet points for my patients, which is very empowering, because it may then turn into me being a sort of like a triage individual, right? Where I turn around and say, listen, I've assessed you. And yes, we can use a conservative intervention like movement modification and spine hygiene and core stability work, but that may only get you about 60 or 70% of the way. And let's be real about pain, right? Because that movement may not eradicate the pain. In some individuals, absolutely, but not everyone, and especially just my demographic. So then I'll say to them, the combination of a conservative and a medical intervention like a transforaminal epidural injection or something to that degree, that may put you in a very strong position so that I can then continue to do my rehab with you. But those resolutions and treatments are all dependent on what the diagnosis and the outcome of my assessment is, right? So someone will never come into my room and I look at a scan and say, oh, you've got a big disc bulge, therefore, you've got to do A, B, and C. No, not at all, right? Let me learn about you. Tell me about you. Tell me, what sports do you play? And because I'm a strength and conditioning coach, when they tell me about the sport that they're doing, I can break that sport down in my mind as they're talking to me, and I can actually visualize the mechanics of what the spine is going through. Yeah. So that gives me their history, right? Then I'll do an examination, because the history doesn't give us everything. I need to examine, and I need to put certain loads through their spine, and I need to see if, a muscular stiffening strategy can reduce the pain, etc., etc. And once I've got that, I still may need some special investigations to determine my diagnosis. Yep. So the special investigations may come in the form of MRI scans, CT scans, SPECT scans. And again, I hear all the time people are so dismissive of scans. I think people are dismissive of scans because A, they don't quite know how to read a scan, right? And I've spent literally thousands of hours, right, with my radiologists, who are probably the best in the UK, and we discuss it. And so I know scans, spinal scans. Okay, let me just make that permanent very, very well. Okay, I can see a scan, I can see things on scans. So, and when you have got an examination outcome and you've got scans, you can correlate, and you can see what is important on the scans, and you can dismiss what is, hey, an incidental finding, or just...
Which one comes first, the assessment or the scan?
That changes. That's a good question, right? Because again, you will hear that we should never look at scans before we do an assessment. And that's not true, right? So I will tell you this, and I'm saying this not out of arrogance, I'm saying it out of confidence, that I can look at a scan before my assessment and the scan doesn't bias me anymore. Right, I've done it so many times that literally I can look at it and I know what I'm going to see. Right, but there is one instance where I will always look at a scan before I do an assessment, and that is if someone has had spinal surgery. I will not put my hand on them until I know what their spine looks like now, so that it gives me an assurance of that when I do my testing, I'm not going to disrupt anything, because after surgery, you have a different spine.
That makes sense.
And I'm not prepared. Okay. I'm not a risk taker, right? I'm not a gung-ho risk taker. I'm going to fix the world's back problems, right? I'm very, very considered. I think about the words I use. I make people feel very comfortable. And if they've had surgery, I'll always say to them, I want to look at your scans because I want both you and I to feel comfortable that I can examine you.
It's interesting because I'm a huge, obviously, proponent of conservative care. And we often on my podcast, we probably, shit on scans, and probably a little bit too much than we should, to be honest with you. But that's probably because we are coming from a place of dealing with being so involved with Dr. Locke. He's out there seeing a lot of new grads. He's teaching people every weekend. So that's one part of why we talk curriculum, because me and Stephen have experience, obviously, with our schooling. He has experience with his schooling. He goes and speaks to students quite a lot. So he's got experience with the curriculum. But he will go and talk to these people, and that's just one thing that he's really picked up is people will attach themselves to scans to build confidence because they don't have it in their assessment. The famous quote from Locke is, put your scans in the corner. It's what he says to a patient, put your scans in the corner. Good thing about chiropractic is the amount of radiology training that they get. And Stephen, you know this, right? Like when you have a patient and you're going through all your paperwork, you're literally told to look out for one of 50 to 100 red flags that could say, hey, we may need to get imaging. And one of those would be, have they had surgery? So it makes complete sense in that situation that imaging would be ordered before you'd go on, or imaging would be looked at before you'd go put hands or even think to treat the patient if they've had spinal surgery, right? Like that would be common sense. I don't think anyone would argue with that. But the notion of people jumping to scans first, creating a diagnosis. And this is particularly done quite a lot in chiropractic and the Gonstead method. So drawing up lines in a dark, X-ray kind of chamber, the focus becomes so heavy. And then you start putting your diagnosis on the x-ray. So you put like PRS, posterior right, superior, or you put ARS or ASRA, anterior right superior atlas, or whatever. So you'll start putting that on. In those situations, the focus can become too much on the scan. But keep in mind, in the first place, they're looking for a subluxation, which is something that's very difficult to define medically outside of the large cohort of what chiropractic medicine is. So yeah, but yeah, I just wanted to give you a little bit of background into like.
No, understood, Brogan. And I'm looking at it completely differently, right? And again, the patient population group who do come to see me, they're not the acute, I got back pain, a week ago. I don't deal, I genuinely do not deal with those patients, right? I've got colleagues that if someone does phone me and say, listen, I hurt my back, 7 days ago and I'm in spasm, I can't move, I will say to them, I need you to go see my colleague down the road who is an absolute superstar osteopath. He's incredible. I work with him all the time. Yep. And him and I have, we've worked together for many, many years, and he looks after my acute patients. And then what may happen is if that patient gets particularly bad as, months go on or years go on, and they've seen multiple people and they just haven't got that resolution, or nothing's ever been explained properly to them as to why this is going on, they come to see me. So that's why scans play a really important role. And what I do is I'll ask every single patient, right? And this question is standard, right? Would you like me to explain your scans to you? And if the patient says no, then, hey, no problem. I'll look at the scans, but I'm not going to say anything. In all the thousands of spines I've seen, I've only ever had 2 patients say to me no.
Wow.
Right. So there was one woman who was very, very anxious because she had read the report, which the report is different to me explaining the scans. But it was so ingrained in her head that I said, absolutely no problem. Right. Interestingly enough, she left the room at the end of the assessment, and her husband, all right, who was with her, said, please explain the scans to me. So I did. And he said, that's just not what the report said. And I said, well, of course. And I said, don't blame the radiologist, right, for writing that report. Because, and again, people are so up themselves. They say, radiology reports are so bad. Yeah. Well, hold on a second. Whoa. I work with some of the greatest radiologists in this country. Do you know the pressure that these guys and gals are under? Some of them have to report 60, 70 reports a day. There is human error there, or they're going to try and report as much as they can because they don't want to leave anything behind. So it's not that they're writing a bad report or a good report. We need to take it into context and appreciate the pressure that these individuals are under, especially in the UK system, where a lot of them do both private and the National Health Service work. And, our National Health Service is in a crisis, especially for MSK stuff these days. So again, you've got to take a step back. You've got to breathe. You've got to quieten down and put everything into context. And then you'll be able to deal with it.
I remember when we were in college, our professor said to us, okay, we're going to do an assignment. Here's the scans, write a report. And you had 80 reports being written by students, third-year students, that at this point had done 3, maybe 4 diagnostic imaging papers, right? So we'd done a few by then. Even talking between my friends, it was like everyone was writing different things. What's unique with chiropractors is that they can take x-rays in their office, interpret them themselves. You don't need to be a DACBA or you don't need any extra special training. That's right, Stephen?
Yeah.
Stephen's really good at x-rays. Like he'll send me stuff and go, what's this? And I'm like, oh, is that like cotton wool appearance? Like, is that Paget's? But he'll send stuff through to me, and if I don't get it right, he'll shame me. So
I don't shame anyone. So I was curious. So you are probably one of the only non-clinicians in the world who have radiology rights, especially in the UK. Like, how did that come about, and how do you decide when some sort of imaging is required?
Unfortunately, I can't disclose exactly how it all came about.
That's okay. That's okay.
just purely because I'm involved in the spinal medical team. Beside knowing the right people, Stephen, I very much had to prove myself. When I was invited onto the MDT, now I'm talking, these are the heaviest hitters in the spine world in the UK, in the medical, in medical terms. They were not very receptive to me at all, right? Genuinely, they were not. And they were pushing me. They were pushing me for answers, and they would propose certain things, and they'd wait to hear what I said. And and I was very, very respectful when I got on there, and I didn't say much in the beginning, so they didn't really listen to me at all if I did say anything. And then I started to present cases, and then they would ask me certain things. And it was through all of that, I got imaging rights, a whole bunch of things. Getting rights was not easy. I had to prove myself in front of the radiology board. So it doesn't, I didn't just, oh, you're a nice guy, you got rights. No, not at all. Okay. No. So that's how all of that came about, Stephen. And then when do I call for scans? Well, interestingly enough, most people that come to see me already have got scans, right? Most people. However, what they will do is, a lot of people come to see me and their scans are maybe a year, 2 years old, symptoms have changed. It's at that stage I'll call for a scan, right? And then when you call for a scan at that stage, that's when you do see that possibly now they've got a facet cyst, because they've had so much instability over the last year, and they've been doing, yoga 5 times a week. And now all of a sudden they've got radiculopathy, and it's not from a disc, because they 68 years old, and the likelihood of a disc going at that stage, is far less than you getting a facet joint cyst or something to that degree. So, it's case dependent.
It's very interesting. I like that story. Yeah, thanks for letting us. Thanks for telling the story for the first time. Really appreciate it.
Yeah, I didn't even think about it, because no one's ever asked me. So
I mean, I always try to do my due diligence when we have a guest on the show, because obviously we really respect the people that come on, and we're very grateful for your time. So me and Stephen try to do our research, and we would hate to have someone on and not know some of the nuances of their world. And it's funny, because that one thing we just spoke about was this one thing that me and Stephen, I was literally watching the video last night thinking about it. It was on my mind yesterday when I was with my family thinking about the radiology rights, thinking, interesting. And then Stephen messages me about it, like, oh, I'm going to ask a question about and I was like, oh, that's so funny, because I was thinking about that myself. And I thought to myself, I'm not sure if he'll share about it. In my head, I was thinking, I'm not sure if he'll share about it, because obviously it's ongoing, so it's fair enough not to go into the details. But
we all come in from very different perspectives. We've got rheumatologists, neurologists, neurosurgeons, orthopedic surgeons, physiotherapists. So everyone comes in from a different perspective, all for one combined goal, and that's to get the best outcome for the patient. Not for any of us to prove that we are better than anyone else. Not at all, right? We are there particularly so that we can help our patients. And that's the key thing.
It's funny, you talk about everyone coming together with their own skill set. And as much as someone being a specialist is a benefit, it can also be a negative, in the sense that, a hammer is going to see a nail. And so I have a friend that's just finishing up chiro college, and the mentors will be looking at an issue and they'll be talking to him about it. And then he'll bring a perspective that's kind of rooted in McGill's mythology, which these other chiro clinicians, they know nothing about. Like, we don't teach McKenzie, we don't teach Mulligan, we don't teach McGill.
Yeah, the thing is it's a biomechanical thing. It's biomechanics, and Stu will tell you that, right? It's what he saw in the clinic. It's what he saw when he did radiology, and again, a lot of the surgeons, they don't interest themselves a lot in biomechanics, because they don't really have to, right? Or they need to know, if they get a standing x-ray, they need to know, the sacral slope, and they need to know the angle of lordosis, etc., and the pelvic incidence. I get that, especially when they're doing a deformity surgery, and they need to understand, do we use a little T-lift cage like this, right? Or do we use a proper lordotic, hyperlordotic A-lift cage like this? So I get it. But for most part, right? They're not going to spend a significant amount of time on biomechanics. But the interesting thing now is the surgeons who I'm working with, they're calling me and they're saying, Joel, what we want you to do is we want you to assess this person and tell us indeed, do they need surgery? Because they're on the cusp, right? They fall into that category of they're not emergency cauda equina and they're not, just purely conservative. And can you do an assessment and then write a report and tell us, do they indeed need surgery? Like, should we discuss it further? Or can you work with them for maybe the next year and, can we get away with something without going down the surgical route? So that's again another massive demographic that I've got now, right?
So,
is that's coming from the surgeons because they want me to do the assessment to mechanically determine what's going on.
So, in regards to your patient interaction, how important is communication, especially in a world where you're likely having patients walk through the door? They likely have some type of negative experience with what someone's told them, right? I mean, this can go from, like we touched on before, this can go all the way from a surgeon talking about saying some kind of buzzwords that may upset someone, all the way down to someone having a sore elbow and someone saying you've got tennis elbow, you can't do anything for 6 weeks, or your spine's out of alignment from a chiropractor, or your core's weak from a physio with no proper assessment. So there's just all these things, kind of that move and intertwine and through all different professions. But the one consistent thing is there seems to be a lot of strong communication happening. And I know that comes from a place of people wanting to give a diagnosis. But I am interested with you, how important is communication, and in terms of how you're explaining things and how you're labeling people? Because people love to label things, right? And then some people can take that upon them and it can have a real psychological impact on them. So a little bit biopsychosocial and then a little bit also communication. What are your thoughts on that?
I think communication is absolute key. There's two things that are key for me before I even put my hands on someone, before I even look at their radiology, right? It's number one, and the most important, is pattern recognition, right? So when that person walks through my door, do I know who I'm dealing with? Right, straight away.
Yep.
And I'm sure you've heard, Stu's even told the story because I told him, right? But I once had a patient walk through my door. I knew exactly who I was dealing with just by the brand of shoes that he was wearing. Straight away. I looked down because I make it my business to know that stuff, right? So he walked in and he was wearing a pair of Ferrari shoes, or it was quite a few years ago, right? And I knew straight away, right? Because now I'm not judging, right? But I'm categorizing. There's a certain category of people who will wear Ferrari branded shoes. Okay. So no, and it's not a good thing, a bad thing. It just is what it is. It's an observational thing. So straight away, I knew how to deal with him, right? I knew what the words to use that could get him on my side so that he's compliant with, listening to me and doing doing whatever needs to be done to get him better. Okay. So pattern recognition, number one, and then number two, communication, right? How you speak to that person. But I can only determine how I speak to my patient if I recognize who they are, and I've got story after story after story. You don't use the same language with them. And this is where I give praise massively. It sounds bizarre. I give praise to my upbringing because I was born in Johannesburg, one of the most, roughest cities in the world, right? Yeah. Now, by no means did I grow up in the slums of Joburg, but you needed to be very street smart at a very young age. And because of that, I learned exactly how to deal with different people, different styles. So with all of that stuff, that gives you the wherewithal to recognize someone and treat and be on their level. Right. And that's really what I'm doing. I'm meeting them at their level.
The way you describe that is so sharp. I mean, it's so attentive. It's really something that I wish more would hear. People need to hear it. Clinicians, therapists, manual therapists, whoever you are, we need to be attentive. Communication is so important. You can't communicate to everyone the same way, but it just takes time to learn that. It takes time. And this is one thing I love that you say. You've coined the phrase. I've heard it a lot. Everything matters, right? Everything matters. Yeah. Can you touch on that a little more for us?
Sure. And literally, and I've said this plenty times, right? Not that I'm big on social media at all. I probably lose more followers than I gain on a week by week basis. But interestingly, I've always said my hashtag is everything matters, right? And the reason I say that is because in my world, and I can only ever speak for me, right, is everything does matter, right? How they sit down, how they stand up, how they are made to feel when they walk in my facility. Are my reception staff attentive to who they are and who they're coming in with, right? Do they respect them? Do they, do they offer them water? Do they make them feel comfortable? So everything matters until it doesn't, right? Because there might be something that I think matters, and then I realize when I talk to them, well, that's irrelevant now. Let's move on to the next thing. And Stephen Covey, the author of 7 Habits of Highly Effective People, turned around and said, first seek to understand, then to be understood. And that should be the number one principle, right? Understand your patient before you try to demonstrate how smart you are, because your patient doesn't give a to how smart you are, right? They couldn't care if I sit on a medical team. They couldn't care if I told the neurosurgeon this, that, what, right? All they want to know is, can they just tell me their story? Am I willing to listen? And am I willing to understand their perspective? And if I am, hey, man, we've opened our lines of communication.
I love that quote. And how beneficial would it be if more of us were able to take that on board and apply it to our lives, not just our interactions with our patients, but you look around the world right now, people are at total different ends of their belief systems. Just how important would it be, if we could understand each other better and if we could be more understood by people? And I love that your whole persona is very much respectful, very much listen to understand, and that's really refreshing. One thing I do want to touch on: how often have you told a patient that their pain is non-specific, or use the term non-specific lower back pain?
I've used it before. I may determine that this particular individual, right, has non-specific, non-mechanical back pain, and I don't have it in my remit to be able to diagnose exactly what it is. So now I need to send them to someone who may be able to give them a specific diagnosis. So I'm not afraid to say that. I'm like, hey, man. So now, do I believe that non-specific back pain exists? No. I believe that there is someone out there for that particular patient that may have the technology and or diagnostic skills, because we don't have it all, right? We don't. There's not one person that's got it all that may have the ability to do so. Now, interestingly enough, I've dealt with some phenomenally psychologically fragile individuals, right? And giving them a specific structural diagnosis would make them way worse, just purely because of their anxiety and a whole host of things. On that basis, I know at that stage as a clinician, it's better for me to pass that person on to someone that's got different skill set to me, to then communicate in a language that they are very skilled at doing with that particular patient. And I'm not panning, I'm not pushing the patient off. I'll stay there. One thing I'll tell you, right? I think that every patient who comes to see me will always tell you that I'm willing to go the extra mile for them, right? I never just push them off and say, if I can't help you, goodbye, right? I'll contact their clinician. I'll speak to them. They can call me anytime they want. We can get on a phone call. My PA does all of that because I genuinely want to help that individual. So yes, I've used non-specific back pain within the context of a particular case before. Do I believe that, if you're crap at assessing and you just say, well, you've got non-specific back pain, I'm like, okay, well, hold on. Different ball game,
That's what's, I
Yeah.
mean, obviously with the pain science movement, it's very heavily followed and it's even in some curriculum now. And it's very widely accepted that when it comes to lower back pain, it's very biopsychosocial and there's never really one cause. There's just been this influx or this increase in that diagnosis as an umbrella diagnosis. So, when you hear McGill talk about it, you hear Locke talk about it, that's the provocative factor, I find. But like you said, context.
It's context,
You
and
described it perfectly.
yeah, and the thing is this: I work very differently, right? Because I'm not formally trained to, work for only 25 minutes or 30 minutes and have a diagnosis within that period of time. I'm going to use a lot of I'll use an example of the physiotherapists on the National Health Service,
Yep.
right? These physios have got 15, 20, maybe 30 minutes, right, to work with someone who's probably got a whole bunch of yellow flags on top of their MSK pain and everything else. And that physio really has to do as much as they are able to do within the confines of that time restriction that they've got with someone that's probably a phenomenally complex case, right? Not musculoskeletally, but mentally. So in that instance, if they turn around and say to that patient, you've got non-specific back pain, and because most of your life you've been sedentary and we want you to move, just a little bit of movement, whatever that movement is probably going to offer you an amazing resolution. I can't argue that point. That's a very, very valid situation and valid point to potentially use non-specific back pain. Now, in my world, someone comes to see me for 3 hours, right? And within 20 minutes, I say, you got non-specific back pain. How's your sleep? How's your marriage? Touch your toes, lean back, do a couple Jefferson curls. That's a different ballgame, because then I'm really being an infant in how I communicate with that individual. And I'm insulting their intelligence, because I do deal with people that A, can afford to see me, right? And B, have seen many different people beforehand. So again, if these people on social media are speaking about the National Health Service or something to that degree, they need to contextualize that. They need to disclose that. They need to say, this is who I'm working with, and hence why I have to say non-specific back pain, because I'm not afforded the luxury of 3 hours with them. Different game.
That's your experience, right, Stephen?
To a degree, yeah, because I dabble a little bit with insurance, but I see a decent amount of cash rate people as well. But yeah, so obviously if someone's confined to with their income and what the insurance is gonna do, they may not want to pursue a longer appointment where we can dig in deeper and figure out what might be going on. And so there is that degree of inability to provide the best appropriate care, which can be frustrating. But I'm not strictly confined to insurance. I know a lot of chiropractors that are, and obviously most of the PTs in the US are confined to that. That does probably create a whole host of why we do have the chronic MSK stuff that we do in the US and globally.
But by the same token, right, it doesn't mean that non-specific back pain exists.
It does not.
It just means that you may need to use that as a diagnosis to get the person moving.
Yes.
Yeah, it's the context.
Context is key.
I've used it a couple of times with patients that I felt like them having the diagnosis would either create a psychological phenomenon that I didn't want, or they just did not care about what was wrong with them. They just wanted me to help them figure out how to make themselves better.
Correct.
Yeah, and we have a lot of people listening to this podcast that are in that boat. We've got chiros and physios, and they get to see their patients for 10 minutes, 15 minutes, 20 minutes, 30 minutes at a time. And we often talk about with Stephen, we often talk about strategies where you can be as comprehensive and you can do the best job you can in that time if you are restricted to guidelines based on insurance or other things like a boss, or a mentor or someone that's teaching you a certain way of doing it. And that's also really helpful for people, because us three are probably in all three different areas of the spectrum. Joel, you dealing with a lot of very specific cases, and the people that I've been seeing has been quite specific, but it'd be less so because I'm not going into as much detail with scans and stuff. And then obviously, Stephen, you pretty much deal with anyone, like from like I say walk-ins, but you know what I mean. Like anyone can book an appointment with you. Like I'm only seeing people through referral. You like anyone can walk in with you, so you get a bit of everything. And if you get a really complex case, you've shared before on this podcast how you actually spread out strategically your the time you spend with them, the types of questions and the parts of the history you'll go into at different times, how you get to know them, what exercises or what interventions you'll do up front versus further down the track. And so it's important, to talk about that as well and encourage the people that are not forced but are in a season of their life right now in their profession where they're seeing people 15 minutes 30 minutes a day per session, and not to be discouraged, because it's like you can hear all the specificity and just how amazing, Joel, like what you're doing, and then there's so many people doing what you're doing, Stephen, as well. This just takes me to a question I have written down here for you, Joel, is what are some tips, tricks, encouragements, wisdom, anything that you could give to a new grad that is seeing 50 people at 15 to 30 minutes per session? What are some insights you could give to that person? Because there are so many of those people listening to this, and it's overwhelming for them to hear how much specificity you would put into your patients, I would imagine.
Brogan, that's probably one of the hardest questions I've ever been asked because I'm trying to think, I don't know whether I could answer that specifically, but I'll answer it like this. People always phone me and they say, Joel, listen, we want to get into dealing with back pain patients. We're a personal trainer and we want to qualify McGill, or we want to go into physiotherapy or whatever it is. And we want to help people with back pain. What should we do? Okay. And I said, don't do anything. Just practice, right? Just hone your skills. And hone it for the next 6 months, 12 months, 18 months, 2 years. And I said, get these really, really good, right? And get these good and just practice as much as you can. Practice on family members, do whatever you can. And then, then you can start thinking about the bigger picture, getting all qualified and all the fancy certificates behind you. That's neither here nor there. But I said, get to know who you're dealing with. Don't think that, you had one client walk into the gym and they had a bit of back pain and all of a sudden, you gave them a couple of bird dogs and now they're all, good and dandy. You're a back pain expert now, you're not. Because trust me, and Stu always says this, right? This is something really interesting. Stu always says to people, be careful what you wish for, because you may just get it, right? Because when you get involved in the world of back pain, right, or any musculoskeletal pathology for that matter, you're getting yourself involved in a world that you've got to really know what the hell you're doing. Because what you say, what you do, what you prescribe, who you refer to, everything can have a significant consequence on that individual's life. So don't think, personal trainer is a bit different, right? Because I can say it because that's who I am. I'm qualified as a trainer. So personal training is a bit different, right? You can train someone, you can train them for 10 sessions, never see them again, whatever. Okay, it is what it is. But when you're dispensing medical advice, when you're dispensing advice that can potentially have a significant, emotional consequence on someone, man, you really got to know your oats. It's not about having a qualification and thinking you're the best in the world. I'll tell you this now, and this is 100% true, right? Everything I say is 100% true. But I reflect on every single session that I do. Everything. I will go home and I will sit there and I will say, everything that I said, was that right? Should I have said something different? That daily reflection on, because I only see one patient a day, right? I don't see, I'll see follow-ups in the afternoon, but I only do one consult a day. And for me, I go and I think, did I give them everything? Did I miss something? And if I missed something, I'll come back to the office. I'll look at the scans. I'll go through my notes and I'll email them. And I'll say,
Wow.
I said this in my note, but I've just done a bit more investigation, or I've spoken to my surgeon, or I've spoken to my radiologist, and we've seen this on your scan, and we believe that you may need to go for A, B, and C, right?
Yep.
I never just go home and think, did a consult, it's done. It's a full-time thing. My brain is constantly thinking about my patients, always, never stops.
That's very self-aware of you to be like that, because obviously so many people wouldn't even know that they're not doing that in a sense, and I suppose it's, as you grow as a person, being self-aware is just one of the very important things that I've really come to understand. Being able to reflect, so important. And I think just we can get stuck in the motion. We're human, I understand, but like you said, when you are telling people, you're giving people, possibly giving them hope, or possibly sometimes, like I said, we're human and doing the opposite, putting a label on someone. It's just so important. Like you said, you got to know your stuff. And that's just one of those things where I think more people absolutely can say this statement conclusively. In my opinion, more people need to be more self-aware and need to definitely look back on their practice and say, hey, what can I do better? And like you're saying, you're going to follow it up. You're going to let that person know. We can't know everything. We can't all know everything. And if something pops up and you have to do further research, having that attention to detail, and also taking the ego out of it and saying to your patient, here, this is what I found later. So, there are people that wouldn't do that just purely because of ego, and that's something that is mind-boggling.
I'm too old for ego, but I'm like genuine. It was my birthday a couple of days ago. I've got too much gray in my beard. So for me, it's like, hey man, I've committed myself to the process, right? It's what I do. It's all I do. I only see people with spine that they've got spine issues. And if I've committed myself to the process, then hey, I've got to go way above and beyond what that person expects from me, and because, and it's not about, I've got, this is my scorecard, I'll get 17 out of every 20 people better. It's not that, right? I've gone way beyond that. That was how I think 10 years ago.
Yeah.
But since my surgeries, I've had a life-changing experience. Okay. My surgeries changed my life. There's no two ways about it, right? So on that basis, I now have this awareness, right, when I'm sitting with a patient, and it probably puts the patient at ease and at comfort to know that I've been through all of those things, right?
Yeah.
So I have this responsibility, I think it comes out of a Marvel character, something. What's that
Spider-Man.
saying? Which one?
Spider-Man. Great
Spider-Man,
power.
What's it with more power comes more responsibility? Is that what it is?
With great power comes great responsibility.
There we go. That's exactly what it
quote,
is.
Ben Parker.
Ben Parker. Well, and that's exactly how I feel, gentlemen. It's because I've been given these privileges. I've had the ability. I'm one of, myself and my colleague are the two only people in the world who teach McGill stuff, right? I've been given all of these things. And with all of that, I have to take what I do very seriously, right? Very seriously. That's why you'll never see me prescribe anything on social media. I'll never say this is a good exercise or a bad exercise. And I'm not saying people who do that are bad or good. I'm just saying it's not something that sits comfortably with me. So therefore I don't do it, because someone might come here and, hey, I might have to give them a certain exercise, which could be potentially controversial on social media because it works for them. But I don't need to justify to a social media audience because I only ever have to justify myself to one individual. That's my patient, no one else, right? I don't have to say a single word to any other individual on this planet. It's my patient, because that's the person who requires my skills. And that's all I'm interested in.
Having the awareness, right? It's fairly important, I would say, for people, as you're saying, that are treating other people's. It's like I touched on it before, being self-aware, but having that greater awareness. Also, you seem very thankful to be where you are, right? So like you're outpouring from that position of being thankful, and just a little like something I've picked up over my years. It's very hard to be angry or jealous or depressed or upset when your foundation is built in being thankful. It's a real, and that crosses over many religions, many beliefs throughout society and throughout civilization and throughout history. Many of these books that people read, it comes back to this kind of point of being, your foundation is like, hey, I'm being thankful for what I have. And the minute that is your position, that is your, whether it's spiritual or emotional position, is being thankful, you tend to just be a lot happier in life. And I can imagine, like, whether you're serving people in terms of patients, whether you're serving people in you're in law enforcement, or in the military or in public service, or whatever it may be. Just to take a little side note, that's one thing I've picked out from the best in the world doing all different things. Many people, they kind of outpour from a place of humility and thankfulness. Another big question I have for you: there are people listening and they're saying, okay, Joel, I'm on board. I'm on board, Joel. I'm drinking your Kool-Aid. I love what you're saying, picking up what you're putting down. And is there a way that people can do consults with you online? Is there a way that people can connect with you, whether it's people listening that have issues directly, or whether we've got clinicians or therapists that have problems, they have patients that they need help with? What is the best thing to say to those people? Do you do online? Do you see patients online at all? Do you mentor other? Is there any type of mentorship things that you do with clinicians? Obviously, you do the McGill stuff, so you could touch on that. But yeah, what would you say to those people listening?
I'm going to start with the mentorship thing. It's a request I get on a weekly basis. My PA has to deal with that every week. Joel, is it the same answer? I'm like, at the moment it is. I don't do mentorships, Brogan. And one of the reasons being is because the difficulty for me is because now I'm living in a medical world. The patients that I see generally don't want anyone to come and observe, right? Because for example, if I've got any post-surgical patients that have had failed surgeries, or they have this huge regret that they went for the fusion in the first place, there's a whole bunch of baggage that comes with that, right? So mentorships for me now are just not something I do, purely because I don't have the capacity, time, and or energy. And it's not something I don't want to do. I'd love to do it, right? Because to share that knowledge and experience would be fantastic. I just, at the moment, my life doesn't allow for that. So that's number one. Number two, I get a lot of requests from clinicians emailing and saying, Joel, listen, I've got a patient. Can we, myself and my patient, consult with you online, for an hour or so? We've got questions to ask. Yes, I do that. Okay. So, and they can just contact performancerx.co.uk. Just the contact form goes straight to my PA, or it goes to reception and then to my PA. And because people mustn't contact me on social media, it's not my medium, right? So I don't really reply, or it's not for me. So it goes through my PA. And then I don't know whether you guys are aware, but about a year ago, I started a new project called the Spine Exchange.
Yep.
And the Spine Exchange was initially a surgery support group. Right. So it was like a Zoom-based support group, but it has morphed into now becoming a very comprehensive resource for anything and everything to do with spines and spine surgery. So it's spelt so THE, and then spine, SPINE, XCHANGE. thespineexchange.com, thespineexchange.com. So it's just got one E.
Yeah.
And I interview surgeons. We've got a YouTube channel. In fact, on this coming Tuesday, we've got a free YouTube webinar. Myself and one of the surgeons whom I work with, we're doing a webinar here, and people can come on and ask questions about, spines or spine surgery, their back pain, anything that they want. And it's becoming a large resource, not just nationally, but globally as well.
Very
so
cool.
We've got American surgeons on there. So that's become a really big project of mine. Yep. And close to my heart because, of what I went through. So that's cool. Taking up a lot of my time. But yeah, I do virtual consults. Most of my virtual consults, again, are, people asking me, should I go for surgery? Should I consult with a surgeon? Can you read my MRIs? So I do a lot of that stuff.
That's cool. And I will put the links in the show notes below, and also, if it's if on social media and stuff will be available. But if you're listening to this on a different platform, go ahead and click into the show notes, and you can click straight through. Otherwise, you obviously just clearly said the Spine Exchange, spelt with an X, no E, and then it was
one E, yeah,
and then also Performance RX.
performancerx.co.uk. Yeah. So that's my gym. That's where we run all of our personal training. I run my consults. So I'm downstairs in the room, in my consulting room. I got upstairs. I got again, phenomenally grateful. I got a wonderful personal training gym here in London. Never thought some little dude from South Africa was going to run a personal training gym in London. So again, I'm very grateful. But it's where everything happens. My trainers who work for Performance RX, they've been with me for many years. They're extremely skilled. They look after, if I do a consult with someone, they'll look after the ongoing training. If that person needs anything, from a training perspective. So we've got everything in the house. Yeah.
I like that. So one of the things that I really like about you, I think we can connect on is, exercise, movement, training, bodybuilding, that type of thing, right? You were a bodybuilder. I found it hard to find any photos online, but I did while I was watching a video of you. I think you were showing us through your workspace. I saw a photo on the back. So it looked fantastic. So that, that's really cool. And
I don't want to scare your viewers with me in a thong.
No, yeah. Oh, don't worry. We've had bodybuilders on before, and I always put the photos up. I have a lot of respect for bodybuilders, but one question I wanted to ask, and would be cool to get your thoughts on. One real big thing Dr. David Johnson talks about, the neurosurgeon from Brisbane, with the CFMC, he talks about differentiating between exercise for general health and then obviously movement proficiency as an intervention to restore proper movement patterns, establish a better baseline for movement and health. Could you discuss, in your opinion, number one, why exercise in a broad sense is so important, and then follow that on number two, why specific interventions in restoring movement proficiency or motor pattern or movement with people is also so important, and why it tends to have such great results?
I think exercise has many benefits, emotional, physical. It's as humans, we are designed to move. We are not designed. I've got kids, and unfortunately now, kids are building up friendships over mobile phones. I'm like, for me, that's bizarre. I'm an older generation, and when we wanted to meet kids and meet friends, we'd go out to the park and play, and we'd go on jungle gyms and do a whole bunch of things. So I grew up very physically active. I started martial arts when I was, I think, 7 years old. So for me, my whole life, I'm nearly 50 now, but my whole life I've been physically active. Bodybuilding, jiu-jitsu, kung fu, MMA, you name it, man. Yep. That's what I did. And I just think exercise has so many collateral benefits to it. It also teaches you resilience. It actually will teach you to differentiate between pain that is welcoming and pain that is harmful, right? It's a great teacher. And, if you are aware of what it is teaching you. So, and especially with the context of back pain patients, I am not an advocate of don't do anything, right? That doesn't fall into my toolbox.
Yep.
You got to do something. I don't care what it is. Yep. Man, go walk, walking is probably for your spine, the most therapeutic form of exercise in existence. And so I'm a huge proponent of exercise.
Mm.
There's a major difference between a movement pattern and a formalized exercise. I don't think they're the same thing.
Mm.
Now, this is just my opinion, and everyone's got differing opinions on this. But, Mrs. Jones picking up 2 packets from the grocery store is not the same as putting her into a gym with a straight bar with a wheel aside and getting her to deadlift for 8 repetitions. So when someone, when a young trainer turns around and says, "Ooh, we got to deadlift you because it makes you lift your groceries better," I'm like, whoa, hold on a second. They're not the same thing. From a neurological perspective, neuromuscular perspective, they're 2 different things. You grab a bar, you're crushing that bar, you're locking your lats, you pushing your knee, all the cues you need to secure yourself to optimally lift the bar is different to using a hip hinge to grab grocery bags and walk, right? So I think when you teach people optimal movement patterning, right, whether it's in a gym context or a clinic context, whatever it is, right, I think you're teaching them efficient ways of doing things, right, that may be beneficial in certain instances. The reason I say that is because if you're asking me about what I feel about spine hygiene and the use of that, right, what I'm going to say about that is that I think some people overcook spine hygiene. And I'll tell you that straight off the bat. I've had people come in here. Now, I've had 7 surgeries, right? And if I want to pick up one of my models, right, I'm going to pick up my model like this. Because if I can't bend my spine to pick that up, I have a pathology, right? So if I was to bend and all of a sudden I had radicular pain going down my leg, I get it. Can I take that radicular pain away by creating more neutrality within the spine, migrating the pressure to my hips? Yeah, I can actually take the pain away. Perfect. Now you can use spine hygiene for that. But honestly, my thinking is, if you can't bend your spine to pick up a cup of coffee, you have an issue, a major issue. Now, people come into my facility and you can see straight away that they've read, a book or they've done something and they haven't quite got the subtleties of it, right? And it's like they put their mobile phone down like this, or they move like it. I'm like, why are you doing that? Well, like, what's wrong? It's because that's not quite normal, right? Now, if you go into a gym, right, and you utilize the spine hygiene principles to pick up significant load repetitively, hey man, we're on the same boat, 100%. So there's a time and a place for everything, and it's quite biblical, right? So Solomon said in Ecclesiastes, I don't need to tell you, Brogan, okay, there's a time for everything under the sun, okay? And King Solomon was the wisest of them all, right? There's not one clinician that exists on this planet that's wiser than him, right? So on that basis, for me, there's a time to bend, right? Of course there is, right? And I'm not going to blow my back because I'm fused at L5 and S1 by picking something that weighs virtually nothing off the table. So it's very, very context dependent and particular to that patient. But I've seen people overcook spine hygiene, man, that they're in pain constantly. And then the minute you relax it a little bit, now I'm not saying throwing caution to the wind, but just, I can bend my spine. Of course you can bend your spine. It's all good.
Those people are the ones that they take the McGill they blame McGill method because they're like they've done the spinal hygiene thing, they're doing the robot, and it's funny because they teach them to relax, they teach them to flex, and then the person feels better, and they're like, oh, lumbar flexion, under load, it's fine, technique doesn't matter, and they make these massive conclusions. And one question I do have for you is, what are your thoughts on the hypothesis or the understanding that establishing a greater strength and a greater baseline gives you more room to go into these certain positions without injuring yourself? Do you think there's a correlation between more general strength and a less likelihood of injury? Because obviously many people work off the hypothesis that if I can get my deadlift and my squat to an adequate level, simply picking up the groceries is going to be a trivial task, of which is a very low percentage on my capability. Even if I'm not bracing, getting ready to do the lift, I'm just functioning at a higher baseline. I know certain people in the industry, like Matt Wenning, has established and integrated this belief system into training military people that have 15 kg packs, 20 kg packs. They're going to be able to twist, move, flex, roll, jump. They try to push their baseline so that they have a greater capacity and a lower likelihood of injury. Is that a hypothesis or correlation that you think is relevant?
All I can tell you on that, Brogan, is that I've had some seriously strong dudes and gals come into my place, right? And they can deadlift some seriously big numbers, okay? And they blew their back bending over, tying their shoelace, So for me, I can't get my head around you just increasing your absolute or your relative strength within an exercise, and all of a sudden that being uber protective, because there's so many factors that can cause things to occur in your spine, right? Everything from facet arthropathy to, the disc herniating and a whole bunch of things, the ligamentum flavum increasing and buckling and a whole host of things. And so what I'm going to say to contextualize everything is that you could probably get away with something until you can't.
Yeah.
Okay.
Yeah.
And as to whether it's like someone doing a Jefferson curl, right? Let's talk Jefferson curl. I'm sure many people could do a Jefferson curl and they can increase their load tolerance over time. Okay. But how do you know what that person's going to tolerate in 10 years' time? You've got no idea, right? Mm-hmm. So you can't just isolate that and say, okay, well, if they're strong at a Jefferson curl, that they can do anything and everything. Because one of the major problems, and we're seeing this in spine surgery, people are outliving their spines, right?
Yep.
We are now doing surgery on people who are, and speak to Dr. Johnson about this. I'll guarantee you he's doing surgery on people who are in their late 70s and 80s, right? Because you can get away with a whole bunch of stuff when you're 30, 40, maybe even 50s, okay? But what does the future then hold, right? Are you running headfirst into a brick wall? I can deadlift, 200 kilos, so therefore I'm more resilient in my everyday tasks. Well, I don't know about that, right? I know some people that have never deadlifted in their life and they're pretty much pain-free, So again,
pain is complicated.
Hey man, we're talking seriously complex here, man. This is not go do a Jefferson curl and all of a sudden you're going to be able to, jiu-jitsu yourself out of every situation.
That is the narrative that is heavily being pushed now, is the body can adapt, biological tissue can adapt to any stressor. The IVD, regardless of the research that McGill and others have done, although it can make small adaptation processes with the ground substance, proteoglycans, stuff like that, largely a certain fraction of people believe that it can adapt to anything. So as long as it's progressively overloaded, they can get as strong as they want. But it is an interesting thought that you're saying you can do that now, but what about 10 years? What about another 10 years? We all know that the body goes through various types of degeneration and collagen fibers are going to change over time. Ground substance changes over time. That is definitely like an ideology of, as long as you progress it, you can get away with bending your spine under as much load as possible. And there are people doing that on social media, but it's a fairly new craze, so we've yet to see the negative impacts of that.
It's a year or 2 years old now that everyone's doing all this stuff. Let's wait. Yeah. And that's the interesting thing, right? Is that look at the medical world, right? What are they trying to do in the medical world? right? To be the next, superstar Jeff Bezos in the world of spines. They're trying to do everything and anything to repair a human disc so that they don't have to fuse it and or replace it. How much closer are they to achieving that goal? Zero. Okay. They've come out with things to seal up the annular fibers, but we know from embryology days that the human disc is never exposed to external elements, cerebrospinal fluid, blood, all those type of things, right? And we know that the minute the internals of that disc are exposed to the externals, right, around the spinal column, we know that there is a degenerative process that then starts to take place. And that degenerative process, okay, is always going to be more powerful than the adaptation process that occurs in that disc, because you're trying to adapt something that's degenerating. It's just, that's part of life. So yes, you may get adaptation around your spine, muscular systems, ligamentous structures, right? But you're not going to have an adaptation of that particular disc, because, as I say, all you got to do is look at the medical world. That's what everyone is trying to do. They can't do it. They can replace a disc. They can fuse a disc. They can't heal a disc. It doesn't exist. Most of these people that are saying these things, they've never even seen a disc before.
I'm interested to know whether you align with McGill's thought process around not necessarily a positive adaptation, but an adaptation towards the specific intervention or task being done. And he obviously uses the belly dancer versus the powerlifter, right? And the changing of the ground substance and the slight stiffening or more motion that can move through an annulus. That type of thought process, because this is where people get really confused. We wrote a paper on why the annulus fibrosus doesn't positively adapt or fully heal, right? And we cited every paper we could find. Just does not seem like the annulus can positively adapt significantly. It doesn't seem like it's really healing. It's laying down scar tissue, fibrous tissue, whatever it may be. It's not really ever fully healing. This is what the research said, but we got a lot of kickback, a lot of angry people. And then we also got a lot of McGill followers that were asking us, hey, I'm confused, because McGill says that he often uses the example of a belly dancer versus a powerlifter, saying, you're able to make small adaptations of the annulus specific to the task you're doing. And that confuses a lot of people. Would you be able to bring some clarity for them?
Yeah, I'll make it very, very simple. Okay, so that everyone understands in the most simplistic manner, right? You choose your sport chooses you. Simple, right? So you are genetically predisposed to being able to do something really well, right? And it's very, very rare you get those occasional freaks, right, that we have seen before, that are phenomenally flexible and extremely powerful, right? We've seen that in the world of Olympic weightlifting before. Those are freaks. Those are the outliers. That's not the norm, all right? And that's what people don't understand. It's like when they use that stupid example all the time, scoliosis doesn't matter. Look, Usain Bolt. But no one quite knows if Usain Bolt is licking any injuries outside of his public persona. I don't know him. I can't speak about him. So I can't quote the fact he's got scoliosis, therefore, everyone who's got scoliosis can do anything. I'm like, it's the most bizarre thought process. Like, when did humans become so simple in their thinking, right? So on that basis, I think you choose your sport and your sport chooses you. So, for example, I'm currently dealing with a world level discus thrower, right? Now, the last thing I want to do with her, because she needs a phenomenal amount of rotational power through her hips, right? And if you look at the top discus players in the world, throwers in the world, they actually don't rotate through their spine, right? It's a whole body rotation. So the last thing I want to do with her, right, is put her in a position of where she's getting really flexible and mobile in her spine, right? I want her to be stiff there, because the amount of rotational power that she's generating, if she generates that through her spine, she'll rip her spine apart. So on that basis, I truly believe There's a genetic predisposition to what you can do and what you will adapt to from a movement perspective. Now, I'm not as smart as Stu. Okay, nowhere as smart. That's why I always say, whenever I lecture with Stu, I say, everyone, please forgive me. I'm a little bit slower, right? Because I'm just not as smart as he is. So he would be able to discuss the ins and outs of the details of the adaptation process. I'm looking at it more from a gross overview of whom I see in clinic. And when I've got the yoga individual, they usually have a very specific mechanism of pain, which is very different to my powerlifting individual. Do I treat them the same? Hell no. Does everyone get the McGill Big Three? That's the biggest joke in the entire world. No. Right? For some people, it's the worst thing in the world. For other people, it's fantastic. And if people think that's the genius of Stu McGill, they don't know Stu, right? If on his, if his legacy is 3 exercises, oh God, my heart would break.
That's what people misrepresent his position down to pig research and the Big Three, and it's just so disappointing.
The Big Three. Do you know what I'm saying? The guy is so smart. What he's done, what he's contributed to the world of spines goes way beyond what the Big Three could ever do. Do you know what I'm saying? It's insane. So on that basis, it's to simply answer your question, Brogan, I believe you choose your sport chooses you. Now work within those confines.
Yeah, absolutely. It makes sense. It's very interesting, the different takes people have on that and how aggressive and passionate people are about the annulus and its capability to adapt or make changes. I find it very fascinating and strange, if you know what I mean.
Yeah, but they're losing the big picture. Do you know what I'm saying? They're losing the fact that more important than the adaptation of the annulus, right, is the patient. Just help the damn patient and outline a plan for that patient, right? Patient doesn't care if the annulus adapts, doesn't adapt. They don't even know what the annulus is. So again, it's are they trying to prove how smart they are and how much research they read? Do they even know how to absorb and dissect research, right? That's another question. Honestly, how many people read the conclusion that is on PubMed versus the whole paper, which is 17 pages long?
Abstract warriors, that's what we call them.
They're abstract, exactly. Okay, is that what they call the abstract warriors?
Yeah.
So on that basis, I'm like, you know what? These people are arguing on stuff I haven't got time to get involved in because I'm just too busy trying to help my patients, man.
Yeah, you're getting it done, which is, I suppose that's more than we can say for a lot of these people that they do spend a lot of time on social media. You got to wonder how many patients they're seeing. What you said about the mechanics of the spine versus creating power and talk through the hips is a very interesting one, because I do hear a lot of people talk about disassociating movement from the spine to the hips and certain things like a golf swing or various movements like that. And there are people, they disagree with that, and they try to put forward this hypothesis or this ideology around training rotation through the lumbar spine to produce more force in that type of context. And that seems to be kind of always adversely put up against the style of training or intervention that you just explained. Do you want to give us your ideas on why trying to train the lumbar spine to create massive amounts of force can be problematic? I
can only speak about, again, the patients who I see. And I see a lot of rotational athletes. So I see a lot of golfers, this young athlete who I'm dealing with at the moment, a discus player. And the interesting thing is, because of the amount of rotation that their sport requires, there's this perception that they should train rotation outside of the context of their sport, right? So get into the gym, grab a cable and do, rotations. And the interesting thing is, before we discuss training rotation and should you train it outside of your sport. So if you are a golfer and you require a lot of rotation repetitively, should you then try and increase your rotational power through your spine in the gym, like doing certain cable type movements like this, and really putting a lot of load and speed through the spine. Because again, normal rotation through the spine is fine, right? Because it's designed to do that, right? But then adding load, increasing moment arm, and really putting a lot of speed and power through there, that's a whole different ballgame, right? We're not discussing this is apples ain't apples anymore. So what you need to do is you've got to go to the structure of the spine, right? Now, the spine itself, segmentally, is not designed to handle a lot of rotation, right? Because the disc itself has got it's got annular fibers, right, that are orientated at different angles, okay, or opposite angles of each other. And you've got roughly about 20 or 21 different layers of annular collagenous fibers around the disc, right? And the disc itself doesn't have a very strong resistance to rotation. So what it needs to assist that is it needs the facet joints. And the facet joint's function, its primary function, right, is to resist rotation. So now the problem comes in not just purely discogenic, but what I get to see a lot of is rotational athletes have a lot of facetogenic-based pain. And when you look at their scans, they've got facet arthropathy, they've got effusions, so, they've got fluid in their facet joints. And then you CT them, and their facets are as hot as hell, right? They are bright, and showing you the metabolic uptake in the facet joints. So on that basis, if we reserve their rotation for their sport and help them train hip internal, external rotation, power generation in, let's say, a place like the gym, because let's be honest here, we've all seen that as golfers have got stronger over the last 20 years, the rate of spinal injuries is increasing. Okay? You take a look at a lot of the golfers, right, in the 70s and 80s, they weren't deadlifting and squatting and going crazy with weights and putting heavy rotational loaded movements through their spine. They were training rotation by training their sport, right?
Yep.
And yeah, of course, everyone's going to get injuries. There's no sportsman or woman in the world that's injury-free. I'm like, that's bizarre, okay? I don't think there's any active human that's completely pain-free. That would also be a bizarre thing. Everyone's got a niggle here or something going on. But I honestly, as a strength coach and as someone who deals in spines, I don't see the validity of taking a rotational athlete and loading them up just purely based on the mechanics of what the spine can tolerate. I don't think that's going to increase their ability to produce power. I think it's going to shorten the longevity of their career, right? Yep. Now, different ball game, if you take a medicine ball and you teach them, bam, to move through the hip. Hey, I get that, and they're creating that rotational power, but they're generating it via a structure that can tolerate that, being their hip. Different ball game.
I suppose it comes down to the proficiency of which you are doing those power-based motions and movements, right? Because like you're saying, these golf players are getting stronger, but under whose direction, and how? Because that strength, if it's non-specific, generalized strength, yet we're expecting them to get better in a specific manner, it's crazy.
It doesn't work. Everything needs to be very specific.
Yep.
And I always say this to my athletes, right? You should be spending more time practicing your skill than you should be in the gym, right? Now, it's different if you're an Olympic weightlifter or if you're a power lifter. Your skill is in the gym, or a bodybuilder, right? I'm talking about my track and field athletes, my golfers, my, American football players. and really the wise ones, the older ones, the ones that have got a lot of wisdom and knowledge, they know exactly that the gym is an accessory to, right? It's not a substitute for.
Yeah.
There's a and again, I think the proliferation of this, you've got to get strong, which is, pushed out on social media. I don't necessarily subscribe to that thought process.
And because right now we're being very specific, right? So we are zoomed all the way in talking about very specific things. Being a powerlifter, I've been that way. I've trained that way. You being a bodybuilder, you've been that way. You know how it feels like to be specific. You know what it feels like to treat someone who's in a specific situation. What I like to do with my more gen pop or general population patients is I'm real big on what I call strength exercise, which is just strength and exercise. I love educating patients, and I'm real taking a step back to the overall. Let's look at the overall lifespan of a human and what they want to be doing, climbing stairs, moving around, being active with their grandkids when they're 80, 85, 90 even, 70 to 90, and just some of the very strong data we have on how important strength can be for that, right? So not just grip strength, obviously, which is a good proxy, but
Sure.
Density, mental cognition, muscular strength, all-cause mortality goes down. And then obviously when we look at VO2 max and look at see how important exercise, non-specific exercise in terms of like zone 2, a little bit of zone 5, we've got research on that showing if you go from being below fit to above fit, it's 50% to up to 65% reduce all-cause mortality in some research. So just taking like a real big step back, do you often discuss the benefits of general exercise with your patients? So because obviously we're talking so specific. If we're talking about interventions, I understand why just pushing one thing doesn't always make a lot of sense. Like saying, well, just get stronger. Well, that can't always be an answer to a specific question. But would you agree that just getting stronger is the answer to general health in some regards?
I am a huge proponent of people getting strong and exercising.
Yep.
Now, can I definitively, and I'm talking about my population, say that just getting them strong is going to get them out of pain? That's a different ballgame.
Of course, yeah.
Different ballgame. Yeah. Now, I very rarely, Brogan, ever have a client who comes to see me who is a non-exerciser. Very rarely. Okay. I don't get that patient population. Okay. My patient population sleep well, they eat well, they exercise. They've got, if they're dealing with any mental problems or emotional problems, they're seeing someone to deal with that. So they've got all of those things checkboxed, right?
Okay.
So when they come to see me, I'm very much about the specifics. However, to answer your question, to move away from the spine, do I believe in exercise? Huge proponent in it. Otherwise, I wouldn't be doing what I'm doing, right? I don't just work in a clinic room, man. I got a gym, right? I got a fully fledged, I got every toy that you can conceivably think of in my gym upstairs, So from that perspective, that's my background. That's what I come from. And that's my roots. And I'll never leave that, right? So I'm a huge believer in that.
That's good.
But when someone says to me, all right, you just need to get someone strong to get them out of pain. Not my population, but
of course.
I've had people sit in this chair, right, that pull trains, that pull planes, right? Literally harness and let's go, right? They've got records for log lifts and the rest of it. And they're in searing, disabling pain.
Of course, yeah.
Okay. Now, am I going to put strength on top of that to get them pain-free? No. No chance. You don't just get them stronger. Sorry. And also, they've told me, right, that this unit is sitting in my chair and he's telling me that some physical therapist said to him that he's not strong enough. I said to him, let me start off my conversation, sir, by telling you this. I said, I have no right. Look at me and look at you. Okay. I said, I have no right to tell you you're not strong enough. Right? I said, you're probably too strong for your own good. I said, now let's get into the specifics of determining what's causing your pain and how do we resolve it. I'm like, you got some wet behind the ears kid turning around and saying to a guy that holds a strongman record, literally, and saying to him, you're not strong enough. Really? Okay, prove that.
And it's that overgeneralization. It's, oh, you've got weak glutes, you've got weak core. These generalizations that these types of clinicians, they learn, they pick up this lingo on social media, and then they just regurgitate it to these people. I've been in that situation as one of the strongest in my country, and someone telling me that. But it's all about specificity and it's all about context, right? Because in the same breath, I'm sure, you could have the strongest person in the world, get them to do a side plank with hip abduction, they'll probably fall over.
Yeah, but that's not strength.
So that's, it's still what, stability?
Well,
neurological motor control?
It's probably a lack of endurance, right? And you will find that when people have a lack of endurance, their time to fatigue is quicker. And generally, people injure themselves. When it was my last rep, I was tired.
Yeah.
Okay.
Yeah.
So Stu will tell you this, right? He found in his research that
it's endurance.
Yeah, it's endurance. It's not taking. So that's why words matter, right? There's a major difference between strength and endurance. If someone can't do a side plank and hold a full side plank, okay, for 50, 60, 70 seconds, but they can pull a train, right? There's something lacking there, and it sure as hell ain't strength.
Well, I can't even get into a side. I can't even do one hip abduction in a side plank position. Yeah, I can squat 400 kgs.
So that's what I'm saying, is that's why you need to investigate, and you then need to use the sufficient terminology to explain to the person what are they missing, right? Yeah. You can't just say your glutes are weak. Firstly, all right, if I went to my medical team and I said, listen, I'm going to present a case, the guy's got weak glutes, what's the first thing they're going to ask for? They're going to ask for the nerve conduction studies. Right, they're going to say, well, hold on. Oh. Joel, where's nerve conduction studies to check L5 and S1 where it mediates the glute med? And I'll say, well, no, hold on. I did a manual muscle test. They'll look at me. They'll eat me alive, man. You're joking. I'm like, weak glutes. Bizarre. Do you know what I'm saying? It's like even when Stu did his studies, man, he was putting probes into people, looking at what the EMG of the muscle activation was. And then you can turn around and say, right, hold on a second. We definitely see some deficit in gluteal, activation. Yeah, we got it, man.
Well, yeah, the glute, obviously glute amnesia is another thing that is heavily contested. But again, something that I feel is misinterpreted, misrepresented, often not understood very well. In my thesis, I wrote a few pages going into it because I felt it was necessary to talk about it just within the scope of movement proficiency. I felt like it was important. Same with core strength. And honestly, you're hitting the nail on the head, man, when you talk about terminology, because it's so easy to say strength when we could be meaning stability, or we could be meaning endurance, or we could be meaning many facets of what strength is comprised of. But people use them interchangeably, and different professions, different clinicians, different people on social media, and people end up confused, frustrated, arguing about these things. End of the day, I suppose the rule that governs it all is context and specificity. So being able to talk with you and go into these specifics is immensely beneficial for our listeners.
I've thoroughly enjoyed this. But I've only got one question to ask both of you guys: is has this been useful for you and your listeners?
Absolutely.
Thank you so much for your time. We really, really appreciate it. I can't say thank you enough, because I understand it's a Sunday night, time away from your family. Everything that you said, it made sense. As you come from a place, you're very humble, but very intelligent. I think we could all learn a lot from you. Everyone that's listened to this podcast will be learning a lot. The stuff that you're saying was really, really awesome. So a really high quality podcast. We'll stay connected. I know we have a joint chat, me, you, and Locke on Instagram. An interesting name to it. So
I didn't come up with that.
So we'll stay in touch. All right, thank you so much for your time.
God bless, guys. Take care.